So Ernie, uh, for this session, I'm still going to present, but we're going to swap roles. You and Reza will be moderating the questions as well as interjecting with any questions or opportunities for discussion as needed. I'm going to present, leaving lots of room for interjection and discussion. So as you're kind of looking through some of the questions, and you're kind of sensing that the audience needs either me to slow down or clarify a specific area or topic, do go ahead and interject. Also, if you have experience on your side that you want to kind of add to the conversation, feel free to do that as well. Really looking for this part, again, to be more dialogue driven than anything else.
Yeah, will do.
Luisa, Hannah, did we ever send Reza the link? I don't see him on the invite.
Yeah, everyone has their own link,
Okay, got it.
or they should. We've sent it a couple times now,
All
but
right. Hey, Brendan. Hey, Richard.
Hello, hello.
All right, so just a quick check. Can you guys access the Q&A? Can you see the Q&A box? And I wonder if one of us can.
I can.
You can?
I can.
Are you able to answer any of the questions in the Q&A? And I don't know, it's a good question because I don't see any
I see
questions.
no open questions when I look at it.
Okay. Does it say only hosts and panelists can see the questions for you?
Correct. That's what I
Yeah.
see. Yes.
What's that?
Hey,
Good
Nikhil.
morning.
How's it going? Ready for day two?
As ready as we'll ever be. We recruited a couple. We recruited a couple of actuaries from Accorded to help address the boatload of questions we're getting. This is going to be a more technical, analytics related session. So I'm assuming there are going to be a lot of questions, and we have Richard and Brendan, actuarial extraordinaires from Accorded, to be able to kind of answer those questions. So Richard, Brendan, I'll be presenting obviously some material, but at the same time, we're likely going to have questions, and if you can answer them to the best of your ability, that'd be great. It will also let you know if there's someone typing an answer to a question. So Richard, you'll see if it says, hey, Brendan is kind of typing an answer to a question, kind of move on to the next. So if we can knock as many of these out as possible, that'd be great.
I also would just tell participants, like people at the beginning, that like, hey, we have two more actuaries. Feel free to ask questions that even if no matter how basic, like feel free to ask them at the chat, and like we'll try to get to them, just to like encourage people, I think, too. If they're lost, they should be able to like ask a question to catch up, basically.
Awesome. And Nikhil, also, I'm going to treat you as a moderator as well. Please do monitor questions,
Sure.
interject with areas that you want to dive deeper on, have a discussion. Everything is fair game. Any spot in the presentation is fair game. So I'll be sure to kind of leave opportunity for you to kind of us to pull up if needed and just have a dialogue.
Cool. I'll use the little hand raise thing if I to interrupt and ask some questions if I see a lot in the chat about a specific topic.
Sounds good.
How are we doing sound check wise? Everything good?
Sounds great on my end. And we have Reza. What's up, Reza?
Hey guys.
Sounds great.
All right. Okay, so Reza, I know you just joined, but formally you and Ernie are going to be moderating. Part of that responsibility is checking questions, interjecting with questions as needed so we can have a discussion and dialogue. Obviously offer up your experiences as needed to provide additional color. Ernie, you as well. And then Nikhil, I think I had told you yesterday that you speak for the the laymen. We tend to kind of go deep and use a lot of terminology, acronyms, etc. And if you find us doing that and needing to kind of make it more clear, please do help us do that.
Sounds good.
100%.
Sounds good.
And then Reza, we have Brendan and Richard, who will when this thing gets all started, I'll introduce them. If Brendan, Richard, you can kind of show your face and just kind of wave, and then I'll let them know, hey, you're gonna go off camera, but you'll be in the background answering those questions. That's how we'll do it.
Cool.
All right, so we have 2 minutes till this thing gets fired up. What we'll do is, Hannah, if you can start it at 9, let people in, and then we'll give everyone about 2 minutes to kind of, well, 2 or 3 minutes to file in, and then I'll look to get started around like 9:02, 9:03.
Yep, I think that's perfect.
All right, cool. So I'll give everyone 2 minutes before we get this kicked off.
Frank, anything that's like super technical, just at the end of the slide, just pause so we can have a little commentary and all that stuff.
Sounds good.
Yeah, my recommendation is for like particularly complex slides. At the end of it, I would just give like the summary, like TLDR of the slide, basically. It's just like main takeaway here is whatever.
Yeah. I adjusted the slides yesterday after some of the commentary to be a little more pull up high level. Like I didn't think it was necessary for us to go into like Dover, etc. when there were folks telling us, hey, we don't know what.
Yeah,
What? I love the Dofer.
this can be a Q&A thing, or like you can do it as like supplementary info.
Exactly, because I just realized this is value-based care contracting basics, not.
Yeah, exactly. We can start maybe the thing today, like in the few minutes as people are really can be like, what questions you have from yesterday, or like random stuff on your mind, and then we can just maybe just do a couple before we go into day 2.
Yeah, that sounds good.
Let's see how many people show. Let's see how many people got scared from day 1 to day 2.
We already have 39 people waiting in the waiting room, so they're the brave
previous
ones.
call was like, hey, I have this value-based contracting thing in the next half hour. Like I need to run to get to it. I was like, I'll see you there.
Amazing.
All right, so
let's
everybody ready?
open it.
I'm gonna start. Here we go. Dun, da, da, da.
I feel like there needs to be like a ribbon cutting, like virtual ribbon cutting or something, like or like the 3, 2, 1 in Mario Kart kind of thing. It's like a visual.
I was gonna say it was the Black Friday thing where
Sure, yeah. People are mobbing it. Too funny. All right, so for people who managed to survive day 1 and come to day 2, if you're an attendee, we'll do the first few minutes doing some Q&A. If anyone has outstanding questions for stuff we went over yesterday, or things that are sort of just on their mind about value-based care, feel free to put them in the Q&A, and we'll try to answer that. We have an army of actuaries this time to handle the 100+ questions that came in yesterday. All good questions, but I can only type so fast. So if anyone has questions, just drop them. You can just drop them in the Q&A now, and we'll try and get to it. Let's see. Are the questions open? I think so, right? No questions. We're good. Just kidding. They're gonna come. I feel it. I feel it.
We
Any
had
questions?
at one point a buffer of well over 100 questions yesterday, so we were doing our best, guys, and we'll continue to do our best today. So we appreciate the engagement.
All right, let's get started on first question. For the pilot negotiation to generate the clinical evidence and proof of concept, do you recommend doing an admin assessment to understand the financial losses that the unit is currently experiencing and see how this VBC program solution can address these financial challenges? I like barely understand this question, so if one of you guys want to take this one.
I'll take it more broadly because I'm not sure if this is going to take it directly, but when people are doing a pilot, depending on their level of maturity, they initially want to assess engagement. And then a little bit past that maturity, they're assessing clinical outcomes. And then past that, they're engaged, like trying to assess utilization and, return on investment, right? So from a value-based perspective, depending on, what you're selling and where in this ecosystem you are, not everybody's expected to drive total cost of care savings in their first 6 months. But you might get a solution. It's their first pilot, but their intent is to drive, reduction in ED or inpatient and so on. So it just depends on where you are. Just reducing general administrative cost or efficiency and so on is a harder sell in this competitive marketplace where there's hundreds of other people trying to pilot something that's ultimately moving the total cost of care.
All right, let's see. There are a lot of questions about medication adherence, just generally, maybe as a concept and how it fits into value-based care. Do one of you guys want to talk about maybe if medication adherence is a thing value-based care organizations care about, if you are a medication adherence company, like any tactics, strategies, etc., that you should consider if approaching value-based care companies?
Yeah.
Frank, you take the quality piece of it and I'll take the affordability piece.
Yeah, I mean, medication adherence, there's a lot of quality metrics around medication adherence that health plans are measured against, and that directly impacts, things like revenue around star ratings and CAPS, which is patient-reported outcomes. But generally speaking, when we think about value-based care, I would say core, which is, are you going to have a direct impact on the majority of the medical costs for that patient? Medication adherence programs and solutions are going to be kind of supplementary and ancillary to kind of the whole goal of managing total cost of care. And so when you think about value-based care contracting as it relates to that specific function, it's going to be something that's more limited in scope on the contracting side. So not the total cost of care, shared savings, shared risk. It's really going to be, how does this solution kind of play a part in that total reimbursement ecosystem, which can be managed in many different ways. Reza.
Yeah, I would say that's 90% the answer. But then there are solutions out there that are pharmacy-based or medication adherence, kind of broader speaking, that are moving the needle on total cost of care, that are moving the needle on reduction in ED, let's say in diabetes and asthma and so on. And they're part of the affordability equation as well. So it just depends on your solution. I would say 90% of the times the medication adherence folks are on the quality side. You're selling into quality, you're impacting revenue. And if you're trying to impact savings, you just have to be a more mature company and you have that type of data to be selling into this part of the business.
All right, there are going to be a ton of questions. Maybe we just get into things because I think we have a lot to cover today. And for all the other questions in the chat, maybe we can just start answering asynchronously. So Frank, maybe if you want to take it away for day 2.
All right, sounds good. We had a lot of slides, so let me go ahead and find the right spot here, and then I think I got it. All right, thanks everyone for joining us for day 2, where we will talk about value-based contract analytics. Thank you, Ernie, for taking us through all of the considerations when thinking about getting into a value-based care contract, both from the clinical ops consideration side as well as the contracting consideration side. As you kind of might have gleaned from that conversation, there were a lot of kind of areas in that conversation that revolved around metrics, data, and what we're going to do really is talk about kind of the core stages and the life cycle of the contract and some of the core analytical requirements that it really takes in order to ensure success in each one of those stages. So I'll be your instructor today. My name is Frank. The moderator is going to be Reza and Ernie. We're going to jump right in and go through our backgrounds. I'm co-founder, CEO of Accorded. My background, I'm a health actuary. I've been doing value-based care analytics and contracting, supporting payers and providers for the last 18 years. Reza, do you want to do a quick intro?
Sure. I'm the founder of Quintuple Aim Solutions. We do value-based care consulting, advising, and investing. And I've been doing population health for the last 10, 15 years. I'm an internist by training.
Thanks, Reza.
My name's Ernie Valente. I'm a health economist. I most recently was responsible for conceptualizing, developing, and implementing value-based care programs for specialist physicians at United Healthcare. And I've worked in health analytics and health economics for over 20 years, typically in health plan environments.
Thanks, Ernie. So we also have Nikhil, who would be moderating questions. Both Ernie and Reza will be moderating questions and adding additional color and discussion to the presentation. We also have two actuarial extraordinaires from Accorded, Richard Way, as well as Brendan McWalters, that will be taking on some of the questions in the Q&A section. So if you do have those questions, fire away. We have more support today to get those questions addressed. We also will have a Q&A time period at the end of the presentation. So we'll be sure to allocate time for that as well. All right, so with that, let's jump right into it. So yesterday, Ernie introduced us to a value-based program called HeartWalks. We're going to be extending this example today to use to describe some of the analytical functions that are going to be required in order to succeed in value-based care operations. So the program itself, just to reorient you, is HeartWalks, which is organized guided nature walks for people with heart disease, improving both their cardiac conditions and their mental health. This is a fictitious program that we made up as to illustrate and hopefully make more clear about how some of these functions as well as examples can be applied. So the benefits for HeartWalks as a program itself, as we discussed yesterday, is improved cardiac health, reduced depression, increasing patient satisfaction, as well as reducing cardiac and behavioral health costs for participants, which means that you are also reducing costs for the sponsors of the participants or those that are paying for the medical care, which is going to be health plans, risk-bearing entities, could be self-insured employers, as well as provider organizations that are taking on risk, so risk-bearing entities. All right, jumping right into it. We got some questions yesterday around data sources. Where do you get all this data to do this analysis and to make the business case? Well, there are three primary sources of data out there. One, there's publicly available reports that you can Google. Many studies in JAMA and other websites that you can use, folks that have done analysis and have summarized and synthesized the results. We have seen cases where, actually many cases, your initial proof of concept is going to come from many of those metrics that you're going to be able to find online and publicly sourced. They're very easy to access. Obviously, they're free. The cons to using that level of information is that usually it's either not credible, and by credibility, I mean it's not being generated by enough data when it comes to population health analytics or how a health plan or insurance company would see it as credible. Or the data itself might not be, or the research done might not be applicable to the payer population in question. And so, we see this all the time where we have population health metrics that say, hey, X% of the US population has, heart disease or is obese. While those metrics might be true, if you're looking to sell to a plan that is looking to implement your solution for just Medicare or just Medicaid or a very specific segment of Medicare or Medicaid, then those statistics and metrics that you pulled off through publicly available resources now may not apply to that population. Demographics is a good example there as well. There's also licensed claims data that you can get and pay for through public and or private entities. Definitely more credible, assuming the right adjustments are made. As I mentioned before, it's really important, and we'll speak to this later on, to ensure that whatever type of analysis you're doing on publicly available or licensed claims data, you're going to want to make sure that you can make all the adjustments to ensure that the populations can and profiles are matching. The cons is that license claims data can be very expensive. You need systems and software and infrastructure to be able to house, store, run analysis on them. And then because the data is at a raw claims line level, there has to be a level of expertise and experience in being able to analyze that data, or else you're likely not going to see the results that you want. Last but not least would be claims data coming from the payer. This is going to be the most credible because your program is going to be applied onto the payer's population. The only cons to this really is that this is very sensitive data. Likely there are going to be security concerns, and so there is a process of being able to demonstrate that you can receive this data and store it and house it and analyze it securely. It's also time consuming, and you're going to need the same level of expertise analyzing license claims data as you are payer claims data as well. But that being said, if you do find yourself with an opportunity as you are in the middle of a contract where you can receive that data, please do take it. It's very, very helpful. It shows that the payer is really leaned in and wants to get something done. And then the data itself, both from an operations as well as an opportunity analysis perspective, becomes very, very effective to making sure, very helpful to making sure that you can succeed in the program itself. Wanted to pause there and see if Reza or Ernie had any additional insights or commentary.
Frank, if you had your clients, trying to, in the very early stages, have something that they want to pitch, right? They just need some minimum data of saying, our idea around, walking with people who are 50 is going to lead to this, right? Like, what's the minimum level of credibility that they need to get their foot in the door, as opposed to, the later you ask for, claims data, the more likely you are to get to contracting, right? Like, what's been your experience with some of your clients' students?
I recommend to our clients that you have to be ready for whatever stage or level that the payer is ready for. Meaning, what I mean by that is that you assume that the payer needs to see something, and if that means a well done formulated Excel model that shows the financial business case based on publicly reported metrics, put that together. If you can say, hey, like, I'm very confident because we have the study that we're working on a clinical model off of that has shown outcomes, you need to have that ready. If you can say, we're also willing to take on risk for these outcomes, and here is how we are going to take on risk and have a fleshed out kind of contract model, that is a great starting point as well. The further you can get along in terms of when they ask for something, for example, hey, we're ready to send you data, can you take it? And you not saying, hey, I don't know if I can take this information, being ready for wherever the payer is, and ensuring that you're not the one blocking for whatever reason what the payer needs to know in order to feel comfortable working with you. So basically having all your ducks in a row in terms of data, what type of contract you prefer, why, all the clinical justifications, and then being ready for when that data does come in to be able to kind of analyze it quickly, is what I would recommend in order for successfully navigating the space.
And Frank, I might just add, I know you're not suggesting this, but this is not an either or choice. Each of these data sources has a distinct value for conceptualizing and implementing value-based programs. Licensed claims data can be extremely helpful for benchmarking an individual program's performance against what's happening more broadly in the market, for example, and that's a role that just cannot be filled by either of the other data types here. And the payer claims data will obviously be the gold standard for evaluating the effectiveness of the program.
Yeah, and if I was going to give you an example based on the heart walk, right? So you think about people's, ultimately you want to reduce, let's say, their likelihood of going to the ER, hypothetically, right? You want to know what's this, like the current ER utilization rates of this population. So having the generic for over 65 may not be the enough, right? It's like, what's the ER utilization rate of the people who are in the inclusion exclusion criteria of our program, who are able to walk, who want to walk, right? Based on the published literature, and then based on what we're able to find, how do we go into this publicly available data to get as close to the payer claims to have some sort of credible pitch. Anyway.
That's right. Just quickly addressing a question. We have a question around how do you get the license claims data? Oftentimes, so there are many like companies that we can share that have claims data to license. Typically, for an early stage company, it's very expensive and resource prohibitive to be able to access that data. So you can go through an actual consulting firm or consulting firms that have access to data that will help you run the analysis on it. All right, so jumping right into the material for today, two topics we'll cover. One, we're going to describe the 5 stages of a value-based contract and the analytical requirements for each stage and go deep on each one. And then 2, how to set up analytical work streams. So let's talk about the 5 core stages of value-based contracts. First stage, we've already kind of started talking about it. Opportunity analysis. Second stage, contracting. Once you define the opportunity, what are the contracts and its parameters that will most likely align incentives and get the payer and provider really on board and excited with the arrangement? Operations. So you're in a contract, how to make sure that you can actually meet the performance requirements of that contract itself. Performance and reporting. Who's doing the performance analysis? Who's reporting it? What are the roles and responsibilities and data needed? Last but not least, reconciliation. You have a contract that stipulates a certain type of payment during a specific period of time, requires analysis and alignment in terms of what that payment is. That's reconciliation. And then finally, taking what you've learned from the first year of the program or the second year of the program or the last year of the program and ensuring that any lessons learned are applied in the renewal itself to make sure that you're fixing any issues that might not have been accounted for in the previous contract. All right, so let's jump into opportunity analysis. So when I think of analysis, I like to think of what questions are we actually answering or trying to answer when we do any type of analysis? So when we think about opportunity analysis, the technical definition is just quantifying the financial opportunities of a clinical program or value-based care model. The question to be answered is, what is the anticipated financial outcome, both for the payer and the provider when adopting a clinical program? It's a very broad-based answer, so we need kind of mini steps to really unpack what this analytical approach is, or to be able to answer that question. So first and foremost, in broad strokes, you need to define your clinical population. We've talked about medical adherence through some questions. Okay, medical adherence, what type of patient population are you looking to drive medical adherence? What conditions? That way we can determine through analysis and data how much these payers are actually paying to treat and care for these members. Once we understand on its baseline how much the payer is paying to treat and care for these members, we then define what the clinical value levers and intended outcomes are of a specific program or solution. So if it's medication adherence, the clinical value levers are relatively clear, right? We want to make sure that they stay on their medication because studies have shown that non-medication adherence results in bad outcomes, higher cost.
So Frank,
yeah, go ahead.
double click on that medication adherence for a second, right? So if you're looking at hospital readmissions, so med reconciliation, med adherence is time sensitive, right? So you need things to happen in that first 24-hour after discharge, because that's one metric you're trying to move. That's both a cost savings metric, and now it's a new quality metric for the plan, right? Versus if you're thinking about, medication adherence that's driving quality, right? So things around statin use and other things and so on, that's more of a longitudinal thing. So even some simple metric, you have to understand, like, which value driver are you trying to solve for the risk-bearing entity, for whoever's going to pay for this.
Thanks, Reza. So once you've identified the clinical value levers, and in many cases it's, hey, I want to prevent, this specific patient from going to the emergency department because we see, a high case of emergency department utilization and or unnecessary inpatient visits. There are hundreds of different service categories you can examine and you can define your outcome levers on. So by no means that we're going to focus on just emergency room and or inpatient admissions, although that is a very popular outcome measure for many programs. Once we've understood what the clinical value levers are, then the analytical requirement is to start drawing a dotted line between those value levers and what the financial cost impact is. And so that is part of the analytical workflow that is required in order to determine what is the opportunity for savings, both on the revenue side and or the cost side for the payer if they were to adopt a solution.
Maybe we can just quickly chat a little bit about what value levers exist here. Because we had a few questions about that. I'll say a couple, and then obviously please supplement me where I don't know. But the big ones I've seen have been, medication management. Can you switch people to different drugs that might be less costly and more effective? Utilization management. So if someone keeps going to the, if someone doesn't need back surgery and maybe they, could have done PT, et cetera, then actually just reducing utilization completely. Site of care, so changing where they actually get care done. If you get home dialysis versus go to, a dialysis clinic, it's going to be very different costs. Maybe you can shift the site of care. Those are the big ones. I don't know if there are, and those ones you can actually demonstrate in a relatively short period of time, which I think is another key here, is like, a lot of times we talk a little bit about day one, you need like 12, 18, 24 month ROI. Are there other levers that you've seen that people can pull to reduce costs?
So what you described, Nikhil, I would say can be broadly categorized into two categories. One is utilization and two, unit cost, right? So your two value levers is, if your solution exists, how do I impact unit cost? Unit cost is for every single service that the payer pays for, how do I reduce the cost of that service? So you mentioned site of service redirection, moving, navigating patients away from facilities to centers of excellence, right? To freestanding facilities that are definitely more cheaper for MRIs and surgeries, et cetera, et cetera. And so you're really reducing that unit cost. Then there's utilization impact, which is they get too many unnecessary back surgeries. How do you reduce the utilization of those back surgeries? The utilization of emergency departments, the utilization of, inpatient readmissions. Those are all utilization-based metrics. Now, from those two really high category kind of things that you're looking to achieve, it could break down into, and I'm talking about like trees that are going to be very, very granular, right? So there are different modalities that you impact those two kind of areas, different types, dozens of hundreds of different types of service categories, et cetera, clinical groups that you can start breaking them down into, episodes of care. So again, it gets very complex very quickly. But what I will say is that if you come into the table and you say, hey, we're going to impact utilization and unit cost, that's not going to be enough, because really what the health plan or any payer is going to want to know is, how exactly are you going to, what is your clinical model? Who do you treat? If you can get as closest to the patient journey as possible, for example, let's use this example, heart walks. They improve the health of a heart disease patients. Great. What does what are the medical services that heart disease patients utilize? How much of it do they utilize? What is the cost of each of those services? That's the unit cost. And what does a solution like HeartWalks look to do in order to change the trajectory of that care? And how does that change translate into financial savings?
The only thing I would add to what's been said is that you also need to consider where you're accessing the patient, the provider, and the provision of health services through things like utilization management, which are activities of the health plan. So, for example, if you think of low-value services like the Choosing Wisely list, avoiding low-value services is a really good way to reduce cost while improving the quality of care delivered to the patient. But the information that one needs to make decisions about low value services is very granular, very clinical in nature. And it's not reflected in claims and administrative data, for example. So you've got to be very close to the patient. Really only the provider of care is in a position to impact the use of low value services. Whereas a site of service diversion, moving someone, instead of having something done in an inpatient setting, having the same service done in an ambulatory surgical center, for example, that you require more, plan level access to accomplish something like that, or direct intervention with the patient. So you've got to consider if you're making a claim about the ability to do these things, you've got to have access to the people and processes necessary to affect them.
Yeah, and we're going to discuss some of this stuff in my talk tomorrow. So plenty of room to get into the weeds of what providers do and some of the experience that I've seen at some of the larger medical groups.
All right. So with that, then we'll walk through a high level example of an opportunity analysis with HeartWalks. These are the punchlines. Obviously, there's going to be a lot of analysis and demonstration that would have to go on in order to support these kind of headlines. So first and foremost, HeartWalks helps improve the health of heart disease patients. Second, health plan is paying $25,000 a year on medical services for each member with heart disease. HeartWalks improves the cardiac health, improves the mental health condition of its program participants. And we've determined that for each patient that participates in these programs, the estimated savings to the health plan is $2,500 per year, or 10%. Yeah, that can break down into many things. Where is that $2,500 coming from? What are you looking to achieve? Like a lot of data kind of representing these numbers. But again, the goal is to be able to kind of clearly articulate, like get to that number, because everything else in terms of a value-based care contract really stems from that. All right, so pro tip for opportunity analysis. Many times you're not going to have access to the payer's claims data, at least early on, right? So you're going to be using external data sources, studies, etc. It's going to be very important to ensure that you know where those studies are coming from, what populations they've been analyzed on, so that you can kind of ensure that you're at least making an adjustment or accounting for those differences when you're talking to a health plan or payer for their population. What you don't want to do is come to the table with, saying, hey, we looked at the study, looks like there's, $2,500 worth of savings for heart disease patients, and not be able to kind of clearly articulate how that population in the study relates to the population that you're looking to sell to or manage for the health plan or payer. All right, so second stage in value-based care contracts, the actual contracting phase. So once we've determined and aligned with the payer that, hey, like here's the financial opportunity of our solution, and we've gotten past that step, the question to be answered through analysis is, well, what is the reimbursement rate and contract structure that align both the incentives of the payer and provider? So this would be, a value-based care contract, ensuring that the payer is reimbursing for quality and outcomes, and ensuring the provider is getting reimbursed commensurate to the value that they're delivering. So when we think about contracting, let's look at it in 4 steps, right? We got to perform financial opportunity analysis. We've done that already. We've aligned with the payer and the program that, there is opportunity for savings. We need to select the appropriate payment model based on the features of the clinical program. So Ernie already discussed, hey, how much opportunity is there for you to kind of actually access the member? How do you find members to participate in your program? Many considerations in terms of, well, depending on what the features of your clinical model are, there's going to be an appropriate contract model to really accommodate for those specific features. Then you need to price the components of the payment model so that the projected financial outcomes for both payer and provider are positive. Value-based care contracting is kind of more of a collaborative team-based approach to contracting. We want to make sure that you're going to achieve the outcomes you achieve and you're going to be reimbursed properly for those outcomes. And then on the payer side, that they'll be able to kind of see those savings matriculate into their kind of financial P&L.
Frank, we're getting a lot of questions about how do you defend the credibility of opportunity analysis and estimates of program savings. Do you have any comments you can make there?
Yeah, so I mean, I think a lot of the credibility comes from how well you can kind of make I would like to call it the actuarial case, but really it's coming to the table and showing that that there's a difference between the data that I'm pulling from publicly sourced data and the population that you're looking to sell to, and then you can list those differences out. You can say, hey, here's why I think here's how we've accounted for it or addressed it, or here's why we don't need to address it because it actually makes a lot of sense for these metrics to be flowed through and to carry over in our analysis, right? If you don't do that, if you just pull anything out from the web and say, hey, this is what I'm going to use to kind of go up to a payer, right away your credibility goes down. Right? They realize that you don't know what you're talking about. How can I expect you to even analyze data that I give you if you don't understand what the difference is between a publicly sourced kind of research paper and how you're gonna, define opportunities on my on my population. So it's really critical kind of for you to be able to do that step 1 on the pro tip. Understanding what those differences are, being able to articulate why those differences are adjusted and how they're adjusted for, and how they're considered into the presentation.
I would also add having a sense of operational friction points that you're going to have, right? Showing that you are not going to come in and say, based on this little pilot that we've done on 16 patients over here, we're going to save you $20 million, right? Like not extrapolating every little thing into a giant number, thinking the bigger the number is, the more likely you're going to get through the door. Actually, the bigger the number is, the more they're going to say, this is not credible. Let's have something that's tangible and so on. One other comment around this contracting for you, Frank, going back to this cardiology example, people, let's say the basic patient is $25,000, right? There's going to be hundreds of patients that are, less expensive than that. And there's going to be hundreds of patients that are more expensive than that at baseline. So both parties, when they're contracting, how do they guarantee that, what's included in this population that we're going to intervene on, they have enough, predicted cost so that there is $2,500 worth of savings? Do you put in things around, minimum previous usage of this or minimum criteria of that? Like, how do you protect against getting too healthy of a population so then a year from now your ROI is not what you planned it to be?
Yeah, so great question. Insurance risk, we call that insurance risk, is essentially kind of the name of the game with these contracts. You're trying to make a prediction about where you're going to get, and oftentimes it doesn't come in the way you expect. And when that happens, there are retrospective measures through reconciliation where you can kind of take a look and say, hey, like, here's what happened, here's what we expected to happen. We probably should adjust for this during reconciliation. But it's going to be incumbent many times, I would say, on the provider to really understand what's driving those differences and to be able to uncover them and have that conversation with the payer, especially if it's, you know, something that happened that it's to the disadvantage of the provider. But that being said, understanding that this is the case, there are many provisions in terms of how we structure a contract ahead of time, prospectively, that allows us to say, hey, these are the very specific features of a patient that allow us to include them in the analysis, right? And so as much as possible, if you know there are going to be conditions that are going to change the, let's say, kind of risk profile of the population at hand, we want to build that in through eligibility criterias and or how you know, a program gets members, right? So sometimes they get members through health plans that are saying, hey, we're going to give you a list of members for you to go out to go pursue. Well, there are ways and algorithm there's a formula in which you can apply to like how that member list gets generated. And if that's the case, we can help, you know, define, you need to help define, okay, well, here's the criteria in which you need to set that list or generate that member list. All right, so going through the example with HeartBox. So again, very high level, but we've determined that HeartBox saves the health plan $2,500 a year for each patient that is enrolled in the program. The health plan will now pay $1,000 per year for each enrolled patient. That translates to 150% ROI for the health plan, assuming that, you know, they're all aligned that there's $2,500 worth of savings for each enrolled patient. After the end of the year, HeartWalk participants achieve more than $2,500 worth of savings. The health plan will actually pay HeartWalks 25% of that savings above $2,500. So this is like an additional added shared savings or bonus component for the program. And so as you kind of go through and you're negotiating, there are going to be, you know, times when the payer wants to adjust a condition, in the contract, the you know, the program will want to evaluate. And so this is where, you know, analysis happens, right? So this is an iterative process. Each time a configuration or a term or clause in the contract it changes, it'll have implications on the financials. And so being able to quickly kind of ascertain like what that impact is it material? Is it immaterial? How does that change how you want to, you know, price these solutions is going to be really critical, because oftentimes, you know, this becomes a huge bottleneck towards the contracting process. So for example, you know, if HeartWalks does some analysis and says, hey, wait a minute, like if we get cancer patients in this population where we can't really control and it's very high cost, like that's not going to be good for us or the payer or the health plan. So we should probably remove them from the eligibility criteria. Well, if you remove cancer patients with heart disease, you're likely going to change the average amount of spend calculation that the health plan is paying for heart disease patients, which means you're likely going to have to change the savings projections, which means you're likely going to have to change the payment model, right? So everything is interconnected and kind of sets off a whole chain of analytical events each time, you know, these changes are being considered.
Yeah, I see this a lot with palliative care, right? So excluding patients that are palliative, a priori or post, you know, for a lot of these things. And, you know, judgment calls are hard to deal with. Yeah, let's keep going.
All right, cool. So pro tip around contracting. I mentioned this before, but really come to the table with a fully fleshed out payment model, right? And oftentimes come to the table with a fully fleshed out payment model based on different types of, I guess, value-based care risk. So if it's like pay for performance, fee for service based, you know, have a perspective on how you would like to get paid under that arrangement. If it's shared savings, upside and downside, have a perspective on how you want that contract to be structured, and the general framework and directional kind of indicators and pricing models. And the reason for that is because, we're coming into a phase where, value-based care is moving away from just pure primary care, and we're looking at value-based care applied to different specialties. Rez is going to talk about this. This is where Ernie has, done most of his work in the last decade. And a lot of, there's still a lot of figuring out in the market, meaning that if you can get to a very clear and concise, fleshed out kind of opinion and model that the payer can work off of, it will help fast track the process. Don't leave it up to the payer. You can, but I promise you it's going to take a long time for them to get back to you if you want them to kind of fully flesh it out and bake it out. All right. Step 3 of the value-based care contract lifecycle, operations. So now that you are, have aligned on financial opportunity, have gotten into a contract, have defined what are metrics of success or performance metrics, how do you ensure that providers, yourself, can meet contract performance targets? So the question to be answered here is that what data can help improve performance? How do I know what is working? And how do I know what is, more importantly, I think, not working, so that you can course correct or implement different strategies in order to ensure that you're performing? So first step, really to implement analytics that can help support and improve the effectiveness of operational activities. What does that mean? That means that, you want to reduce emergency department utilization. Well, what are the drivers of emergency department utilization? Can you kind of look at a population health data set and say, hey, these are risky populations, and maybe we should do outreach and get them before they, head into the emergency department? Again, we use emergency department a lot, but because that is kind of clearly an opportunity of savings for most health plans. You need to measure and track those operational activities and link them to financial outcomes. One of the most important components of value-based care contract in partnership with the payer is that, you're doing a lot internally to ensure that you're going to meet these performance metrics. Make sure you're tracking what you're doing, link them to actual financial outcomes so that you can actually present that to the payer and show them that, and get credit for all of the things that you're doing to ensure that you're meeting those performance targets. Third is that now that you're, a quote unquote value-based care risk-bearing entity, you're going to want to implement programs, strategies, or maybe even bring on vendors that can help you achieve your contract performance metrics. That happens a lot, especially for risk-bearing entities that are primary care now, looking to kind of carve out some risk to other entities that can help them achieve their total cost of care goals. Well, if that's the case, it's going to be really important for you to actively measure how effective those strategies, programs, and vendors are to ensure that you're getting positive ROI. So if we take this example and apply it to HeartWalks. So HeartWalks applies now a predictive risk score algorithm for heart disease patients that signals a high risk of having a heart attack. Having a heart attack will get you into the emergency department. It'll trigger high cost events. It might even land you in an inpatient facility. If HeartWalks is going to be reimbursed and have upside arrangements for total cost of care, they want to try to prevent that from happening, right? So applying, let's say, an analytical predictive risk score algorithm that helps them identify high-risk patients so that they can do outreach is something that they likely would want to do if they can. Now, once they are implemented that program or this strategy and are doing outreach, track the outcomes. Make sure you are tracking, hey, we connected with this patient. They were high risk. We got them in this program. Well, how much savings do we think that generated, right? Track that very, very rigorously, because again, you want to make sure that you're getting credit for all of the hard work you're putting in to try to, improve cost of care outcomes. Step 3, we talked about how as a risk-bearing entity, you're going to want to deploy similar strategies to help manage, total cost of care. And so in this case, this example, HeartWalks has hired Cardiac RPM to provide virtual monitoring services for their high-risk patients that they're on the hook for. HeartWalk pays Cardiac RPM $250 annually per patient, right? And they're monitoring, measuring, they're saying, hey, well, it looks like, for those patients, they're generating $500 of shared savings revenue for heart blocks per enrolled patient, meaning that they've done the calculation and said, hey, like every time we do cardiac RPM on a patient, we're generating total cost of care savings, and it's triggering, additional shared savings opportunity for us with the health plan or payer. ROI, 100%. We pay $250, we're getting $500 worth of shared savings. Again, that ROI is 100%. If it's not, definitely need to reevaluate, right? You want to make sure that you're tracking not only your vendors like cardiac RPM, but you're tracking strategies that you're deploying, right? Lots of different strategies and programs. Hey, we want to do engagement, outreach, et cetera, et cetera. You want to make sure you're measuring how much time you're putting into those strategies and how much it's costing you and what you're actually getting out of it. Because at the end of the day, right, you want to be really putting your resources in areas that are generating the most ROI for you.
Can we quick kind of like pause, because there's a few questions on having multiple providers and how this might work if you're trying to like split one of these contracts across people. Like heart blocks, for example, maybe there's like a primary care group that already is at risk, right, for these patients. So can you just talk a little bit, maybe at a high level, of like, if you're heart blocks or you're a payer looking at multiple providers, how do you think about things like who's on the hook for what, like attribution for whatever, or if you're a startup who's like would subcontract with someone who's already at risk, like how would something like that work?
Yeah, we weren't necessarily going to jump into the DOFR conversation, right? But there's something called delineage of financial responsibility. So sometimes the risk starts at the health plan level, and then it goes to another level, which is a management service organization or an MSO level. And then sometimes it's there and they employ the docs. And at times it's like one layer below, there's like a medical group or federally qualified health centers, right? So if you're selling a solution, there are times that you're selling it into that local frontline entity. Sometimes you're selling it into that management service organization. Sometimes you're selling it to the payer. So it is important to understand who actually has risk for the specific thing that you are interested in moving the needle for. So sometimes you think, okay, well, the medical group is total cost of care, that's obvious, and so on. And then you start working with them, and then they have subcapitated some of the super high risk patients into a program. So if, one of the names of these companies, let's say Landmark or somebody, right? So then you think the company is going to have X amount of high risk heart disease patients, but they actually have a lot less of them because the super sick ones were subcapitated away. But both in terms of understanding all of that in the initial discovery phase, and then in the contracting, figuring out who else is in this marketplace. Like, where's the risk? What is the exact population? And who else is touching these patients in some capacity? I hope that helped, but there's many more layers of this that we could touch over time.
Yeah, I think we can chat about this more tomorrow too.
Cool. All right. I touched upon this as we were going through the steps for operations and analytics, is that, you're doing a lot to try to meet your performance targets. When the time comes to performance reporting, make sure you are tracking all of that activity and are really kind of tying it to, even if it's an estimated amount, how that's impacting cost of care for the payer. You want to be able to advocate for yourself and have robust reporting capabilities to ensure that payers have visibility into your work. Stage 4 of a value-based care contract, performance and reporting. All right, this is a fun one because generally speaking, providers expect health plans and payers to provide performance report on a timely basis. That doesn't always happen for a variety of reasons. that we won't get into. But I guess the big takeaway here is that, if you're a risk-bearing provider, it's important for you to ensure that you're going to have access to the data, and that usually comes standard in any type of risk arrangement. But then also ensuring that, the contract-related performance metrics are being tracked and reported back to the payer so that you're taking it into your own hands, right? Don't rely on the payer to have to kind of calculate and just even trust that the results are right. Make sure you do that yourself, at least validate and verify. So the questions to be answered around performance and reporting are, how are we performing relative to expectation? And I think a really important component is why, what's driving it. There's a lot to unpack there, but that's a really important component. Not just how you're performing relative to what the contract says you need to do, but like what is actually driving that performance. In what areas are you performing well? And in what areas are there room for improvement? All right, so performance and reporting, super important. You really need to know how you're performing, right? And it gives you opportunity to actually fix what's going wrong before the plan year ends. And if you're doing things well, that's even better, right? Take credit for it. So first and foremost, setting up analytical workflows that track the performance of these contract metrics. So that's step one. Also measure and track external variables that can impact contract performance, particularly ones that you have no control over. Ernie mentioned an example yesterday, like price of medical services goes up through contracting, through, you call it medical inflation, unit cost of things go up. And so, being able to track simple things like that, and even more complex things like case mix. How does the population that you're managing change? How did it change relative to what we expected? How is that impacting my results, right? Was there a new drug or medical device that came into the market during the performance period that really could have impacted my results? How much did it impact my results? Being able to take all of those different types of metrics and report back and get alignment with the payer to ensure that they are reserving for performance payments. And this is where, again, if you have a substantial amount of revenue that is tied to performance payments that are coming later on, making sure that the payer is actually reserving, by reserving, I mean planning on their accounting books to pay that out at the end of the year is important, because if they don't plan for it and if it's not on their books, they're not going to be able to pay for it later on, right? I have seen situations where a large amount of money is tied to performance. No one was doing any reconciliation, like reporting or performance reporting in the middle of the year for the health plan, or for the health plan to pay for it. And at the end of the year, they're just like, oh, we weren't tracking this, so we're not going to pay for it.
Yeah, I think that's a really important point, Frank. And it's important to have both parties engaged in the contract, having their own version of performance measures, and to meet, periodically during the execution of the program to ensure that expectations and perceptions are aligned between the entity paying and the entity providing services.
I saw there was a question around Babylon's value-based care contracts. I think context here is that Babylon was a primary multi-specialty virtual care provider that was really aggressive in taking on total cost of care and risk contracts. I don't know the details of those contracts, but I know they grew a lot and very quickly, and health plans were more than happy to kind of unload a bunch of risk onto them. I think that's always a sign where, like, hey, if you're going really quickly with these contracts, you might be giving away a deal that's too good to be true. But at the same time, I think also, like what ended up happening and how quickly everything kind of spiraled showed that like there wasn't that much performance and reporting diligence, like first quarter, second quarter, in the middle of those performance years, and not a lot of reconciliation and improvement in those contracts over time, right? So again, I don't know the details of how those contracts were structured, but two red flags to me was how quickly that they were able to grow with those contracts. Like if, again, a payer is coming to you and say, hey, you want to take my risk and at this price, please take all of it, and they're saying that, then yeah, I think I might say that's probably a red flag.
Frank, there was also a question around baselining, right? So, with some lag in claims, etc., do you want contracts with a stagnant baseline, or you're looking to make an improvement on trend? Like, give us some of your thoughts on some of this.
Yeah. So baselining is part of the exercise of understanding what your population is, and where it's going to go, right? So, if you're a program that is targeting a very specific clinical group, like, let's say not just heart disease patients, but heart disease patients that had a heart attack, for example. Well, how do you baseline that properly? You baseline it with the data. You say, okay, I need to actually take all of this claims data that includes everyone, stratify for heart disease patients, and then stratify again for those who had a heart attack, and maybe even stratify for when the heart attack happens, because you only get them after they have a heart attack and you start managing them. Well, that's a lot of kind of analytical layers you have to go through in order to get to the right quote unquote baseline. Then you have to answer the question of, okay, well, how is this baseline going to change? Because I'm using data that's 2 years old. How is it going to change 2 years from now? Right. So there are things like medical trend that you have to account for. There are things for like, how is utilization changing among this patient population? Are there new therapies coming out, et cetera, et cetera? And then being able to trend that baseline forward so that when it comes time to performance measurement, your baseline is actually reflecting what is expected and happening. And there's a predictive element in that. But at the same time, you should have protections in your contract that says, hey, like, this is what we thought the baseline was going to do. But if there's some crazy thing that happens that, like, it's out of our control, we need to be able to do remediation. We need to be able to look at that, identify it, and say, hey, how do we reconcile this contract potentially differently because of something that happened out of our control? I will also mention again, this is up to the provider to really ensure that they're doing the legwork in order to discover these elements. Don't expect the payer to do that for you.
And kind of the greatest natural experiment in my lifetime regarding this was COVID, right? Because a lot of these contracts were in flight. COVID happened, changed everything, and there was a lot of retrenching and remediation along the lines of what Frank described to make things right on both ends of these contracts.
I don't know if it's something you're gonna go over later today, but there are a few questions on just like, maybe just like rules of thumb about how to think about payment cadence, right? Like, if you take heart walks, or maybe you take like even more intensive provider models, like how much should you think about how much you get paid up front versus, what milestones you should be getting paid on, and like just a little bit of like, how for people who are new to this, how should they think about like where they can negotiate on payment cadence?
I think Reza has a lot of experience with this, but my rule of thumb before I pass it along to Reza is that, for a new program that's not like primary care related, but more kind of ancillary, you need upfront payments to cover your cost of operations. That's round one, right? The health plans are not going to say, hey, we need you to kind of hold the bag until we can look at savings generated. They're reasonable in the sense that you need payments to help you actually operate. And then if you actually perform, how do we kind of true up, and pay you more based on that performance? Reza, do you have?
Yeah, I think most early stage solutions come in with some sort of even though they're selling into a value-based construct, their initial payment model is some sort of a fee for service, right? They do an activity, they get paid a case per patient that they enroll, right? So they could be per enrolled member. If it's something continuously, it could be per enrolled member per month. If it's a one-time activity, right, they get paid a fee every time they do a particular thing. As they get more mature, they want to get to a per member per month fee that's for the population. Maybe not for the entire population, but for that specific, cardiac group that they're trying to enroll. And they just have to be a little bit more mature to be able to navigate that, get that across. So you get all of the cardiac patients, and you enroll a certain percentage of them, maybe you teach a certain amount of them and so on. So with this heart walk situation, you might have in the beginning get paid, I don't know, $20 every time you enroll someone into this walking club or whatever it is, right? But once you're more mature, you say, look, we've moved the needle in this population. Give us all of your cardiac patients. We'll charge, let's say, $1 for all of them every month, and we'll enroll some of them and do education in others and build a community in the rest, and move the entire population $3 of value every month, right? So like you just have to be further along if you want something that's more sophisticated. Lastly, anything that's a service fee, program fee, this might get a little bit kind of wonky, but it goes in the percentage of charges for them that's in overhead and profits, etc. Versus if it's all built into the program, they're going to put it, in the provision of care. So if a health plan is performing really well, one is above the line for their medical loss ratio, one is below the line. I know it's kind of technical, but if you're mature enough, you don't want to have additional fees and things that are separate. You want to kind of lump it all in together.
So extending the example of hard walks to performance and reporting in these very particular steps. Let's say Heart Walks has a target average cost of a program participant to be under $22,500. So that's the $2,500 of savings. If they come under that number, they're going to get shared savings, right? Which is what they want. So they're doing a calculation to say, hey, we're tracking average cost is $2,400. So we're not meeting the target, which is not good. However, when you're looking at all of the different factors that impact average cost, you see that, hey, for this year, unit cost trend, a phenomenon that Ernie talked about yesterday for medical services this year is about 8% higher than historical trend, right? So 8% higher is quite substantial. So if we were to take that and say, well, what if it just came in as we expected and we didn't have that increase by 8% this year? You calculate and you say, hey, our average cost for Heart Walks would be $22,080, which is under the target, and we are meeting goal and are going to generate shared savings, right? So where do we stand there, right? That unit cost thing is not part of the contract, but when we take that into account and this anomaly that happened this year, like we're actually doing pretty well as a program. Okay, great. Well, step 3, report that back to the health plan. Be like, look, based on the rules and strict technical definitions of the contract, no, we don't get shared savings. However, look what's going on with unit cost, right? Like you should have that open conversation, and you should be able to say, hey, like we should take this into consideration. And so now that you've done it, I think plans are very much receptive to that type of kind of collaboration. First of all, they'll be very actually appreciative that you'll do that type of analysis on their behalf and let them know, hey, this is going on for this program. Maybe it's going on for other programs. We need to like see how to ensure that, we protect our partnerships. So definitely do that legwork, because you'll be surprised at how accommodating and amenable health plans are with that type of information and data. And last but not least, benchmarks analysis. So more deep dive analysis suggests that Heart Walk patients that are using high cost providers, right? Not good for Heart Walks, because meaning high cost providers that don't deliver value are increasing their average total cost of care. Well, what does that mean? Well, Heart Walks is now going to implement a navigation and referral program for health plans, cardiovascular centers of excellence network, right? Benefits both parties, benefits the provider, Heart Walks, because now they're reducing total cost of care, benefits the health plan because, they're getting people to the centers of excellence, which they want, they're reducing cost of care as well. So that would be an example of, hey, like, don't just focus on like, are we meeting this metric? There's a lot more that goes on that allows you to kind of really benefit from the type of analysis that has direct implications on how you get paid, how much you get paid, as well as kind of optically how you're presenting yourself to the health plan and partner, right? Saying that you're not meeting target because you're at $2,400 is very different than saying, actually, we are meeting target. It's this unit cost anomaly that's like screwing up like the calculation. That's a very different prospect, especially for a health plan that's looking at you and saying, hey, we need to make the case whether we want to renew or not, right? And then if you can take it a step further and say, hey, by the way, we've done more analysis to suggest that like we can start directing people to and start saving you more money by, implementing a navigation and referral program. Like now you're really truly becoming a value additive partner, a step above just, normal, hey, let's get into a risk contract. All right. So the pro tip, again, just reiterating what we described before. If you have the resources to do it, measure everything. Turn over every stone in the data to help add context to your contract performance, but don't expect the payer to bail you out if you're not performing.
There's a couple questions around just like regulatory stuff, and I'll put that as like, which laws should you be thinking about when you're in like approaching for value-based care contracts? Maybe how does this interact with stuff like Stark law and safe harbors and all this kind of stuff? Do you have just like a high level sort of maybe just like a few rules that people just need to think about when they're engaging payers?
Not my area of expertise.
Yeah, let's pass on that. It's going to open up a can of worms.
Fair enough.
All right, reconciliation and renewal. So this is where you finalize the results and calculate ultimate payment of the current contract, taking in lessons learned and adjusting the renewal contract as appropriate. So questions to be answered here is that how much am I owed? How much do I owe if I didn't perform? What were the drivers of these results? What can we do to improve the contract moving forward? I mean, I don't want to pick on Babylon here, but like, the question was brought up. You have active risk contracts going on, right? You can learn a lot from those risk contracts because you're going to have data coming through. What are you doing with that data to ensure that like, hey, what's going on with these contracts? And how do I make sure that I'm not signing up for, in this case, Homer Simpson looking to sign 10 more contracts of the same flavor, right? So really important, again, to ensure that, you're closely monitoring and understanding what the heck is going on in these contracts so that as you're kind of continuing to grow your business moving forward, you're not kind of getting yourself into more and more of these contracts that are bad. All right, reconciliation renewal. So steps, finalize contract performance metrics and calculate payment amounts. None of this should be surprising if you're doing regular performance monitoring. It should be just a confirmation of the directional indications that you're reporting and aligning on with the health plan, right? As I mentioned before, I mean, you can leave it up to the health plan to do this, but don't. Not because they're gonna try to kind of screw you and purposely make errors, but errors do happen. We see it all the time, right? So ensuring that there are two parties kind of aligning and calculating these performance metrics and outcomes independently and making sure that you can trust the results, very, very important.
Yeah, one of the things here is you might be doing your analysis as you go on leading indicators, or you might be getting your data through like health information exchanges and others. And they're going to be doing their things on claims which has a lag and so on, right? So this process can, you have your things that are highly correlated with the other ones, but they're not always going to be exactly the same. So when this time comes, you have to really pay attention to make sure that there are not things that you want to make judgment calls on, exclusions on, go back and negotiate and so on. So there can be, I've had a lot of experiences with folks that there can be slight surprises here as well. So want to make sure that you have strong analytics and partners to navigate this space.
Out of curiosity, are there certain areas where you see that divergence as the largest between like claims and maybe the data that the provider has? Like, in terms of maybe disease areas or indication areas or types of care models?
Yeah, I think the providers are have the most access to EHR data. So data that they're tracking, hey, here's what we're doing. Like, great, that A1B scores are getting better, or we're doing a bunch of stuff, and like patients are reporting that they really like us, right? Like, that's great, but how is that translating into the claim data, dollars that the payer is actually paying for? And that's where the kind of discrepancy could potentially lie. Most of these contracts, though, I would say, especially if it has any amount of risk in it, will stipulate that the provider has access to that claims data, right? And that the payer will be giving the provider that claims data. So I would say that, like, don't just rely on EHR engagement data, et cetera, data that you're tracking, because again, it might not tie directly. Those outcomes that you're seeing there might not be translating over to the claims data.
Yeah, and pay special attention to your disengaged patients. So let's say someone was involved in Heart Walk and is now no longer involved, but you're still on the hook for them. And you're not following them in whatever your routine processes are. They may have had excess utilization somewhere, out of network, somewhere else, right? So like, if someone is not in your core program for some reason, but you're still on the hook for them, those are the ones who can you might be surprised with.
All right. So once you have finalized performance metrics, again, step 2, analyze all potential influencers of contract outcomes, especially those that you have no control over. Ensure that all parties understand the final measures, as well as the drivers and factors involving those performance measures. This is where you tracking your operational activities and how that's helped the case, very, very important. And then applying adjustments to the contract for renewal as needed. So jumping to Heart Walks as an example again for each of these steps. Let's say Heart Walks finished the year with an average patient spend at $24,000 per year, didn't meet their target requirements. However, we've determined that because of abnormal unit cost trend, the health plan actually has agreed, because of the data that Heart Walks was able to present and furnish, that the average patient spend should be brought down to $22,080. So in that way, Heart Walks will now be able to receive a shared savings payment of $105. That's 25% of the difference, the savings between the shared savings per enrolled patient, which is a good outcome. Again, because of analytics and their ability to kind of dig deep, this is a very different outcome than being able to go to a health plan and say, hey, we didn't perform. Let's figure out how to do something different next year, right? Through deeper analysis, we believe that the patient acuity mix will be different next year, which could potentially put the contract at risk. And step 4, Heart Walks and health plans have agreed that it would be appropriate to adjust the renewal contract for the updated unit cost that they observed this year, as well as for the expected patient acuity mix that's likely to happen in the following year that will likely result in abnormal financial data and outcomes. So this would be an example of the process in which you would do reconciliation and renewal, bolstered by really good, solid, foundational actuarial Medicon analytics. All right, pro tip, reconciliation should not be a surprise. It should be really confirming what mid-year performance reports are indicating. Payers are open, I said upon, but open to adjustments to the contract. Don't be afraid to ask, especially if you have the data and analysis to support your ask. All right, so what did we just review? We reviewed the 5 stages of value-based care contracts and all of the analytical requirements and prerequisites for each of those stages. So starting with opportunity analysis, how that leads to contracting, operations, performance and reporting, reconciliation, and renewal. I want to leave time for Q&A, so I'm going to get through this section relatively quickly, so we can jump to Q&A. How do you set up analytical work streams? Very, very good question that I posed as a part of the content because it is a difficult one to navigate. You know, analytical resources are expensive. They're time consuming. They require investments. So first and foremost, for an early stage company, map out the timing of when you expect to be at each stage of the contract lifecycle, right? Try to set a prioritization list of analytics needed to support the business goals as well as timeline. Don't overlook it. Incorporate the analytical requirements in terms of the time it takes, as well as the budgeting process in terms of what you need in order to procure these capabilities and incorporate them into your strategy. When we see providers taking on risk, oftentimes, and they start growing, they're starting to think about, do we build an in-house team or do we outsource? Again, pros and cons to each one. Let's go over them. Some of the options are actuarial consulting firms. Pros, use when needed. Cons, doesn't scale, especially if you're going to use them as an operational capacity. Build internal teams. Great. Pros, they're always on, always available, flexible, limited scale. Because as you can see, you know, as these risk contracts grows, you're going to need more and more headcount to kind of manage that risk. But then there's also a build risk, right? This is very deep specialized expertise. There's a wide variety of actuaries with different levels of experiences and skill sets and capabilities. You got to make sure you're building it correctly. And then there are software platforms that are definitely scalable, but it's more off the shelf. With potential limited applicability, right? It's like, hey, there's a bunch of data that the software platform is going to throw at you. You figure out how to use it to address your needs, which might not be, hey, can I uncover this very particular idiosyncrasy in this trend that will allow me to tell a health plan, hey, unit cost is not up to snuff. And then obviously, there are many analytically minded folks that aren't actuaries that are very capable. Leverage those expertise as well. Reza, I think you're on mute.
One of the questions that comes up a lot when people are trying to count savings is counting a counterfactual event or something that was prevented. What are your thoughts around, you know, the most semi-scientific way to account for, you know, counting widgets that were prevented?
Yeah, so two things. One, it goes to tying your operational activity to direct kind of financial metrics. So it includes like things that were prevented, right? If you're going to kind of connect, there's going to be an average estimation of like, if I engage this patient and I start doing the XYZ with them, they're high risk. I think I may have prevented an ED visit. Now, on average, it's not going to be one ED visit. It's likely be like 0.2, right? When you're mapping it out, track that. And then once you track it, you're going to say, hey, like all of these activities we're doing are generating cost of care savings. Great. Now, affiliation, and you're looking at the claims data, there are techniques and ways where you can look at that population and say, hey, what is the expected number of emergency department visits I would expect given what I know about this population? That should be reflected in the difference between how you calculate that expected number versus what you're seeing in the data itself. So that's the validation portion of it.
I'm gonna summarize a few questions that have come based on like, what do you do when unexpected things happen after you sign a value-based care contract? So the two that people seem to be talking about are like, one, what happens if you guarantee X% of savings, but you don't reach that? Can you renegotiate? Are payers like willing to renegotiate? Will all the other payers blacklist you? And then the second question is around what about if you do something in a value-based care arrangement and there are like spillover positive effects, right? So maybe you had an arrangement that's trying to improve cardiovascular health, and you discover that like depression scores also decrease, but that wasn't part of the initial arrangement you were talking about. Can you maybe talk a little bit about like what you do, what companies have done if they like enter a value-based care contract and unexpected things happen?
Maybe I can take that one, Frank. Yeah, I think that there are different classes of reasons why results don't end up the way we hope they will, and if you're in a contract with a health plan and you're not meeting your commitments in your contract, how the health plan will react will be very different if the reasons why are perceived to be a failure of your theory of program, or of inadequately done operations, versus an external event. And the example I used earlier was COVID, that you had no control over. I think if your failure to meet performance goals is associated with your own kind of inadequacy, the program's inadequacy, health plans are much less likely to discuss that than they are something that was completely independent of your ability to intervene. However, if there's something that the health plan did, there was a question about, well, we're working with a health plan and they're not getting us to the patients we can help fast enough. If there's something that the health plan is failing to do, I think they will be very willing to talk about that. And again, all the better if you can build those explicitly into the contract so that their expectations are set before you end up kind of quibbling about it later on. The spillover effect, I think, we've talked previously about very rarely are programs implemented uniquely. They're often implemented with many other programs on the playing field, and it can be difficult enough to argue for the independent effect of your program, much less than saying you have a spillover effect and there's more goodness that's occurring that you didn't anticipate. I think it can be very difficult to make that argument. Although, again, if you've got the data in hand, any argument can be made.
And I think that's the point I wanted to emphasize before I hand it over to Reza. Like everything that Ernie says, yeah, for sure, right? You got to be able to kind of make the case, but like this is the difference between like having really capable, solid analytics to help uncover and support that case versus not having it. You're kind of up to the whims of what the health plan decides that they want to share with you and tell the story versus you being able to drive that narrative.
I'll give a tactical suggestion. So if you're having monthly JOCs or joint operating committee meetings, make sure to bring a clinical case to the beginning of every meeting. So if you've had 12 of these things throughout the year and there's been discussion on 12 specific patients that you've helped in a very tangible way, that there's been buy-in on the clinical executives on the other side, that you're actually helping people in a significant way. Sometimes those anecdotal case studies will carry you through when your numbers are not as good as what you expect them at the end. So that's one category. The other is I've had a couple of my clients who've been asked to take care of less sick patients because once they've created stickiness with their patients, the plan has wanted them to do things around quality. Well, now that you've taken care of this population, can you also engage this additional population and make sure they're getting their mammograms and they're getting their screening and so on and so forth. So they do that. They do a great job of it. At the end of the year, these quality metrics are showing like, deltas. But what happens is that baseline utilization of these patients that are less sick dilutes their impact on their primary outcome, which is, inpatient utilization or ED utilization. So in those situations, you go back and say, look, we're going to report out our outcomes stratified by our initial target population and all these extra patients you told us to see. So our impact was this, and this is our diluted impact, right? So there's some of it is through data and some of it's through engagement and clinical and credibility.
Never underestimate the power of a good story to keep your internal champions happy with your, with the project. Just to ask another question that someone asked, which I've always wondered also personally, how do you avoid the benchmark trap? So like for just for context for people, like if you do really well in year one and you manage to show that you brought down spend from your previous benchmark by like, let's just say 10%, then now suddenly you have an even more aggressive benchmark that you have to, hit the next year. So do you have any recommendations on how to think about like, avoiding a benchmark trap? Is it inevitable, or, you know, just out of curiosity.
I'm just gonna pull up the memes in terms of the topic in question. So I think what you're talking about is health plans saying, "Hey, you performed really well. That's great. Now that you've established that good performance, we're gonna set the benchmark, quote unquote. We're gonna set the bar even higher for you to perform next year. So we're gonna make you compete against your own great performance, right?" You know, I hate to kind of sound like a, you know, sound like I'm repeating myself, but I mean, this is where like I think really good analytics kind of help save the day, right? Like if you know as a provider or a program that you're performing really well relative to everything that's going on around you, and you can have that data and show how you're performing really well against everything going around you, you can present the case, and I've seen it done where it says, hey, like that's not fair. You're benchmarking us against ourselves when we should be benefiting and receiving high performance and being reimbursed based on how we're performing relative to our competition, which is what's going on outside of us. You can be able to show that and demonstrate that and really push back against this particular aspect. Now, if you don't have that information, then the health plan is gonna say, hey, like, you know, we're just, you know, moving this ball forward, and really you have no case to make against it.
I think that's great. Well, before I think let people go, I think it's just worth talking about tomorrow. We're going to have some more sort of firsthand experience from Reza as well as Allison on what it's like to actually operate in these value-based care contracts. So definitely, you know, come attend that if you're interested in how it like actually works on a day-to-day basis. Any other thoughts from the panel before we let people go?
I wanted to give a quick shout out to our accorded actuaries that have been diligently answering questions. We've answered 59 questions. Awesome. I think we were in the teens yesterday. So Brendan McWalters, thank you. Richard Way, thank you for your help. And we'll likely recruit you back tomorrow.
For sure. All right. Day 3 tomorrow. We'll see everyone there. Thanks for coming to hang and learn about value-based care contracts.
All right. Thanks all.
Take care, everybody.